The next organ we will be discussing will be the parathyroid and the parathyroid conditions. This is an illustration of where the parathyroids are located on the back or posterior to the thyroid in the neck. The chief job of the parathyroid gland is to regulate the calcium levels through a hormone called parathyroid hormone or PTH. The other function for the parathyroid hormone is to decrease the phosphorus levels as the calcium level increases. So it is for both calcium and phosphorus metabolism, and it does this job by acting on the bone, the kidney, and the GI tract. Specifically, parathyroid hormone will increase the level of calcium in the blood. And remember that this is a negative feedback loop. Calcium in the serum level is the major controlling factor of PTH's secretion. If the parathyroid were to be removed or destroyed, then hypocalcemia can result from this condition. Secretion of parathyroid hormone acts directly on kidneys, causing increased kidney resorption of calcium and increased phosphate excretion. Excessive secretion of parathyroid hormone results in hypercalcemia and hypophosphatemia. PTH also raises serum calcium levels by increasing calcium resorption from the bone by decreasing osteoblastic activity, which is bone production, and increasing osteoclastic activity, which is bone destruction, or the breakdown of bone. This process will release calcium and phosphate into the blood. Uncontrolled, excessive PTH secretion will reduce bone density. Calcium is deposited into soft tissues or excreted. Most common causes for this condition is a benign tumor in one of the parathyroid glands or more, resulting in parathyroid glands not responding to that normal feedback loop of the serum calcium levels. Some of the causes for hyperparathyroidism include parathyroid adenomas or carcinomas, congenital hyperplasia, neck trauma or radiation, vitamin D deficiencies, chronic kidney disease with hypocalcemia. The parathyroid is going to attempt to compensate for the low calcium levels, and then parathyroid hormone secretion of carcinomas that are in the lung, the kidneys, or the GI tract. Parathyroid hormone is going to increase the serum level of calcium by drawing calcium out of the bone. Over time, this will lead to osteoporosis. Because the calcium is now circulating in the bloodstream and therefore is passing through the kidneys, calcium will be filtered out into the urine. The high calcium content in the urine can then precipitate with forming kidney stones. Hypercalcemia above 10.2 creates resistance to the normal flow through the calcium channels that facilitate cellular function. This will result in muscle weakness, constipation, abdominal cramps, lethargy, and confusion. Cardiac symptoms will occur, including bradycardia, heart blocks, and shortening of the QT and ST interval. Laboratory tests that can be performed in order to diagnose parathyroid misfunction or malfunction include the parathyroid hormone. Cyclic adenosine monophosphate is a chemical messenger related to protein and calcium metabolism. It's not normally found in the urine, and if it is present, is a strong indicator of parathyroid disease or hyperparathyroidism. When assessing our patients, we want to be assessing them for the symptoms of elevated serum calcium levels. This will include a musculoskeletal complaints of arthritis or bone pain, or fractures, and these are all related to osteoporosis that can develop from hyperparathyroidism. Elevated serum calcium can result in confusion, fatigue or lethargy, and even psychosis. There's also soft tissues deposits of calcium that can lead to kidney stones and arthritis. The GI manifestations will include anorexia, nausea and vomiting, epigastric pain, Elevated serum gastrin levels from hypercalcemia can lead to peptic ulcer disease and constipation. Treatment for hyperparathyroidism will include the non-surgical treatments of rehydrating the patient and using isotonic saline solution. This is going to be combined with a loop diuretic that will help promote excretion of calcium through the kidneys and lower the serum calcium levels. Administration of PO or IV routes may be necessary of phosphates, and this will help to lower the serum calcium by inhibiting bone resorption and interfering with calcium absorption. Calcitonin will drive calcium back into the bones. So nursing care will include monitoring cardiac function, watching for those changes in the T waves and the QT interval, doing assessments of the I's and O's, prevent injury by relating that the confusion and the lethargy can cause them to fall, and we want to educate on the loss of bone density and greater risk for fractures. Surgical treatment will include parathyroidectomy. Before the surgery, calcium levels must be brought into a safe range. Removal of the parathyroid gland will abruptly drop the serum calcium level. Nursing actions will include pre-op education about calcium and vitamin D management, normal post-op teaching such as coughing, deep breathing, the possibility of voice changes with this surgery in the post-op period. Hypoparathyroidism can be directly related to a lack of parathyroid hormone secretion or to a decreased effectiveness of the parathyroid hormone on the target tissues. The causes can be iatrogenic, and that's the most common form, related to removal of all of the parathyroid tissue during a thyroidectomy, or deliberate removal of the parathyroid glands themselves. Idiopathic hypoparathyroidism can occur spontaneously. The cause is unknown. It can be related to an autoimmune disorder. Hypoparathyroidism can occur with diabetes, pernicious anemia, adrenal insufficiency, and vitiligo. Decreased serum magnesium levels can occur with alcoholism, malabsorption syndromes, chronic renal disease, malnutrition. It can cause an impairment of the parathyroid hormone secretion and may interfere with the effects of parathyroid hormone on the bones, the kidneys, and calcium regulation. And magnesium, recall, is needed for calcium absorption. Manifestations can include a mild tingling and numbness to muscle tetany, severe muscle cramps or spasms in the hands and the feet, and even lead to seizures and mental changes. There are two tests that we do when somebody's had their thyroid or their parathyroid glands removed that we can check for low or hypocalcemia, and one being the Trousseau sign and the other the Shavastik sign. And we will talk about those a little further in class, but be sure and look them up in your book. Assessment: we need to talk to our patients and ask them about head or neck surgery or radiation, any serious trauma to the neck, strangulation or accident, or any other manifestations. Diagnostics include an EEG or a CT scan, and this will show if there are any brain calcifications which indicate a chronic low hypocalcemia. Serum calcium levels will be decreased, phosphate levels will be increased, magnesium and vitamin D will also be assessed. Interventions for care with the patients: we're going to focus on correcting the cause. Patients may be given IV calcium as a 10% solution of calcium chloride or calcium gluconate over 15 to 20 minutes. Long-term oral therapy involves intake of calcium supplements of 0.5 to 2 grams daily in divided doses. Vitamin D deficiency or any deficiency is treated with calcitrol 0.5 to 2 milligrams daily, or with long-term therapy of 50,000 to 400,000 units daily. The dosage is adjusted to keep the calcium level in the low normal range to prevent symptoms of hypocalcemia. Hypomagnesium will be corrected with 50% magnesium sulfate in 2-liter doses up to 4 grams daily, either IM or IV. Patient education will need to be done on the drugs and their regimen, the long-term use of supplementation with vitamin D and calcium, and then diets high in calcium will be recommended, but the patients will need to avoid such things as milk, yogurt, and processed cheeses because of their high phosphorus content. And again, regular labs will be drawn on patients who have hypoparathyroidism.